Good afternoon, everyone. We're just going to give it a minute to let everybody get signed on and get settled, and we'll get started. Hello, everyone, and welcome to today's webinar, Post-ASCO 2026 Melanomas and Skin Cancers Updates, a Canadian and U.S. perspective. My name is Kathy Bernard, President and founder of Save Your Skin Foundation. We are so incredibly proud to partner with AIM at Melanoma today to bring you this critical cross-border discussion. We have an outstanding turnout today from across North America, which truly speaks to how important these updates are to both of our communities. The annual ASCO meeting is where the world's leading cancer research is unveiled. But as patients and caregivers, translating complex scientific data into real-world insights can be overwhelming. Today, we are going to break down those barriers and look at emerging treatment approaches, new data, and what these evolving standards of care actually mean for you moving forward. Before we introduce our world-class speakers, just two quick housekeeping items. First, today's session is being recorded, so you can review it later and share it if you like. Second, we want to hear from you, so please type your questions into the Q&A box at any point during the presentations, and we will answer as many as we can during our panel discussion. So, let's meet our speakers. We are deeply honored to be joined today by two leading melanoma experts. Representing the U.S. perspective is Dr. Vernon Sondak. Dr. Sondak is the chair of the Department of Cutaneous Oncology at the Moffitt Cancer Center in Tampa, Florida. He is a well-renowned leader in the surgical treatment of melanoma, particularly in sentinel node biopsy, and has led major National Cancer Institute-funded research in advanced cutaneous malignancies. Thank you so much for taking time to be here, Dr. Sondak. I'm going to turn the floor over to you first to share your key findings from ASCO. Thank you.
Thank you. Thank you. It's great to be here. Let's see if we got this working right. Okay, hopefully you all can see that. I am going to cover the latest studies in localized melanoma. That is, anything on the skin involving the lymph nodes, and then let our next speaker talk about metastatic melanoma. These are my disclosures. And I'm going to start with how do we currently treat localized melanoma and see what we can learn from some of the things that we've been hearing about both at the recent ASCO meeting and at other recent meetings worldwide. So as most of you know, the standard treatment for clinically localized melanoma is a wide excision of the primary melanoma site. That's the standard in virtually all cases. Sentinel node biopsy is added for patients with melanomas at least 0.8 millimeters in thickness. And then if the sentinel node is positive, those patients are followed more closely and with more scans and tests, and sometimes receive postoperative adjuvant therapy to reduce the risk of recurrence. A big focus of the last few years, and we've heard more about it even at ASCO, is improving on that patient selection for sentinel node biopsy, trying to make a decision for or against sentinel node biopsy based on more than just how thick the melanoma is. So this little graphic shows that today we don't recommend sentinel node biopsy if the melanoma is less than 0.8 millimeters. We always recommend it if it's greater than a millimeter, and we tend to recommend it almost always if the melanoma is in between 1 and 0.8, and it's based on that likelihood that the sentinel node would be positive. Less than 5%, we won't do it. Greater than 10%, we almost always will do it. 5 to 10%, it's a bit of a conversation. There are many people who say, no, I won't do it under 10%. Other people who say 5% is all that I need. But this currently is based just on that thickness, and those thickness levels that I've shown here determine that 5% chance, 10% chance. It still means that 90 or 95% of the time, the sentinel node is negative if we use those thresholds. So what can we do that would be better at improving patient selection? We've been studying a test called the CpGEP test, also called the Merlin assay from Skyline is the company that makes it. The GEP part is a gene expression profile. We measure the expression of genes on the melanoma biopsy slides, on the tissue taken out at the original biopsy. We look at the expression of 8 genes. We include the pathology information, the thickness that we were just talking about, but also the patient's age. And all these results are combined to yield a high risk or low risk prediction. Well, that's all very good, but until we know what that prediction really means, we don't know whether we can use a test like this for sentinel node biopsy. So we did a large prospective blinded multicenter trial called the Merlin 01 trial to look at this test. The patients all had a sentinel node biopsy. They did not know what the test showed. The company who ran the test didn't know what it showed. We just correlated what happened with those test results. And here's what happened. For the entire study group, 1,761 patients who underwent a sentinel node biopsy, 17.6% of them had a positive sentinel node. If they were low risk by this test, which was about a third, 37%, their positive node rate was much lower, 7.1%. And if they were high risk, the 2/3 or so that were high risk, they were nearly 24% chance of having a positive node. That's about a 3 times more likely if you're high risk than if you're low risk. But still, if your cutoff is 5%, that wasn't enough. 7% is still in that zone where we would use the sentinel node biopsy in many cases. So today, we don't use this test very often. It is commercially available in the United States. We use it only in selected patients where, yeah, I wouldn't do it if it's just 5%, but I'll do it if it's 10%. And I'll certainly do it if it's 23.8%. And we can sometimes use that test. Now, tests like this might not just tell us what's going on in the sentinel node. It might also tell us what's the prognosis, because you could imagine that even if your node is negative, but if the genes were unfavorable, if you had a high risk test, maybe you'd have a positive, you'd have a negative node, but a more of a chance for developing metastatic disease. That part of this study is still ongoing. It will take several more years of follow-up to know whether the test was predictive. But I use this as a segue into some of the things that we did see at ASCO, and one of them was using artificial intelligence. And I think this is really the moral of the story. Not that you should use this test or you shouldn't use this test. It's that through studies like this, we are learning how to do better than just the traditional looking at melanoma under the microscope. We've been doing that for 100 years. It works really well. We get a tremendous amount of information from our pathology reports, but it's clear that we haven't got all the information out yet based on the way we do things in a standard fashion. So this study that came from France They used artificial intelligence, told it to look at the slide, see if it could see things that the pathologist couldn't see. And what you see here is that the artificial intelligence program was eventually able to figure out some factors that included the things that a pathologist would normally look at, but some other things they might not have noticed, and helped predict who was better and who was worse off. This also isn't quite ready for prime time. It's just scratching the surface. But in institutions like ours, we're about to transition so that every one of the biopsies and pathology slides on every one of our patients is all digital, all scanned into the computer, and AI approaches like this are absolutely going to help us when we integrate with gene expression profiling, when we integrate with the things we already know. I think the future is amazingly bright for the possibility that we're going to see breakthroughs in predicting who needs surgeries like sentinel node biopsy, who needs postoperative adjuvant therapy, and even questions like who will respond to one kind of immune treatment or who will respond better to another kind. None of this is ready for prime time. All of this is being explored very, very actively, and I think it's really, really exciting. Now, part of localized melanoma, as we've talked about, is still melanoma that's in the lymph nodes, but hasn't spread widely throughout the body. So what's the standard, and where are we going, and what's the future hold for patients who's got melanoma? Their melanoma has already spread to the lymph nodes. We said that if patients have a positive sentinel node, what we call microscopically detected stage 3 disease, they're candidates for postoperative adjuvant therapy to decrease the risk of recurrence. We don't know who is going to recur and who isn't. We still haven't got these tests yet to figure all that out. That means we have to treat a lot of people to hopefully help a few. Everyone gets the side effects, not everyone gets the benefits. Then there are the patients who come to us already with enlarged lymph nodes. Either they had a wide excision in the past and now they develop nodal metastasis, or at the time they diagnosed their melanoma, they've already got a lump that we can feel or we can see on a scan or what have you. That's called clinically detected stage 3. And those patients are now candidates for preoperative therapy. If we already know they're stage 3 before they go to surgery, we can do surgery first. We can do surgery only after we have first treated them with immunotherapy or another form of treatment. And then we can potentially adjust the surgery based on that response to treatment. This all got a big boost from this very, very critically important study called the S1801 trial. It was a randomized comparison. Half the patients with this clinically detected stage 3 melanoma got standard treatment, which was surgery followed by a year of immunotherapy, 18 doses every 3 weeks for 1 year. That was the standard adjuvant arm. The neoadjuvant arm was exactly the same in every way except one. They got 3 doses of the same drug before surgery and 15 doses afterward. So total number is the same, total amount is the same, surgery is the same, everything's the same but the timing. Why would that make a difference? Well, perhaps giving the immune treatment earlier while the tumor is still there before surgery would make a difference. Did it? Oh, yes, it did. It made a big difference. The blue line are the neoadjuvant plus adjuvant, 3 before, 15 after. The red line is the 18 all after the same surgery. And on the other side, you see a breakdown by year of follow-up showing how strong this trend was year after year, such that the patients who got treatment just 3 doses before surgery were much better off. The hazard ratio of 0.67 means they had a 1/3 fewer events, recurrences, dying of cancer was much less among the patients who got their treatment beforehand. Not only that, we learned very quickly that the pathologist here was also critically important. That when we did the surgery and we took the tumor out, the pathologist was finding a degree of damage in the tumor far beyond what we were seeing on a CAT scan or feeling. This isn't the SWOG trial, but this is a related trial. The NADINA trial did a very similar thing to what we just were discussing, but they gave a year of adjuvant therapy versus just 2 doses of neoadjuvant preoperative ipilimumab and nivolumab. And if the patient had a good response, they didn't even get anything. So it wasn't a year versus a year where the timings changed. It was, in many cases, a year versus 6 weeks of treatment. If you were in this green line and had a pathologic complete response, you did extremely well. At 3 years, almost all of those patients were alive and well without any recurrence, and they were nearly all alive, even if they had a recurrence. Only 2% had developed distant metastatic disease. But with each lower degree of response as measured by the pathologist, this isn't how much it shrunk on a CAT scan or how did it feel. This is actually what it looked like under the microscope. And as we quantify that more, as we put that into the computer, as we use artificial intelligence, I think we're going to see even better ways to predict who's going to benefit and how much. But the one take-home message we know right now is that if we can kill all that cancer with 2 doses of treatment before the surgery even takes place, we have the ability to have really great outcomes with less total treatment. So a big focus, these studies were presented at previous ASCO meetings. A big focus at this year's ASCO meeting was what are some new treatments that could be used before surgery to increase the likelihood that we get a complete response. This is a study from our institution at Moffitt that I was involved with, in which we tried triple neoadjuvant therapy. So we went from the SWOG study, which was 1 drug, pembrolizumab, just switching the doses around. The second trial, the NADINA, gave 2 drugs for just a couple of doses instead of a year of 1 drug. This is 3 drugs beforehand. Naturally, each time you boost the immune system further, you're going to change the side effects and increase them. But did it increase the benefits? Well, it certainly looked very, very favorable. The complete response was seen in nearly 2/3, 63%. Another 2 cases had a near complete response. So basically 74%, or almost 3/4 of patients had a complete response or a near complete response as measured by the pathologist. Is that going to be worth it in terms of the increased toxicity? Only time is going to be able to tell us that, but it certainly looks like we may be moving in the right direction. And this slide was taken from an excellent commentary that one of the commenters at ASCO, Dr. Rodrigo Munoz, tried to summarize all our knowledge about neoadjuvant therapy. And he said quite correctly, that bar is getting higher and higher. As we get towards 75% of people having a major response, boy, we may have to pile on a lot more side effects to go higher than that? Is it worth it? How do we strike that balance? How do we find more effective treatments that are less toxic? Same thing for adjuvant therapy. How do we get our adjuvant therapy to be more effective? Can we use vaccines like the mRNA technology that was developed for the COVID vaccine? That's being tested in melanoma. We didn't hear the final results of the phase 3 trial of that at ASCO. We heard some updates on the phase 2, but we're hoping that by the fall, at the annual ESMO meeting this fall, that we may have phase 3 results for a vaccine combined with adjuvant therapy. We may talk more about that in the discussion section. That could be transformative. So I'm sort of going to wind up with some of the questions that weren't answered at ASCO, but we are still studying and looking for answers to. What is the best? How do we balance that adding side effects with adding efficacy for our neoadjuvant therapy preoperative treatment? How do we learn from AI, from the pathologist, from biomarkers, gene expression profiles, which patient needs what? Can we personalize things? And what about doing less surgery? I will show you a couple of examples in a moment because that's something we're very, very interested in. And what do we do when the treatment doesn't work beforehand as well as we want to? And how do we select the best treatments after surgery, whether or not the patient got treatment beforehand? So I will just close with just a couple of things that show that we are now on the verge of avoiding lymph node dissection in many patients with clinically detected stage 3 melanoma if they get a good response to the preoperative immune treatment. We can treat them almost like it was a sentinel node biopsy. Here's what I mean by that. This was a study that used that same 2-dose regimen that I mentioned for the Nadina trial. It's called the Prado trial, but they did something very innovative. They did the exact same thing, 2 doses, look at the response under the microscope, but they only looked at one lymph node. They only removed one single lymph node, not all of them. And the green line shows that if that lymph node had a pathological complete or near complete response, they did extremely well. Of the 60 patients who had that major response out of 99, with 2 drugs, that's about a 60% chance. With 3 drugs, you'd go up to 75%. 59 of the 60 got by without a lymph node dissection. And especially if they only started with one lymph node. And this is something we are doing today. We're putting these marking clips, localizing devices. In the European Prado study, they used this small thing poised on that fingertip. That's a magnetic seed. Here in Tampa, we use little reflecting clips that broadcast a signal to tell us where the lymph node is. And we use a scanner to figure out, just as we do with a sentinel node biopsy, but instead of radioactivity, we have to use something a little more clever. And we can take out just the one lymph node and get an answer as to whether more treatment is needed. Here's an example of what we're doing. Prior to surgery, the patient came in with a melanoma on his back and a palpable node that was positive on PET. We put one of those fancy clips in there. He got 2 doses of 2 drugs, Nivo and relatlimab. And you see that the PET activity is almost gone. That white spot is the marking clip. The spot where the melanoma was on the back is also cold. We were able to take that out, show he'd had a dramatic response, not do a node dissection, do a narrower wide excision, and that patient is doing very, very well. So this is going to lead to a worldwide trial of trying to do this selective index lymph node removal rather than a full lymph node dissection. This is a a poster from the recent ASCO meeting describing that trial that has just started nationwide. So I'm going to close by saying that even with all these modern approaches, early detection of melanoma remains critically important. We're still seeing far too many cases at an advanced stage. If we could just get better and better at picking up melanoma early, we wouldn't need all these fancy treatments and we wouldn't have to worry about the side effects. But overall, one-size-fits-all approaches are giving way to personalized treatments and personalized individual risk predictions and even individual therapies custom-made for an individual patient. And the AI world and these studies of molecular outcomes are just going to increase that. Neoadjuvant treatment has made a big difference in outcomes and in decreasing the extent of surgery for patients with positive nodes, but even though the bar is high, there's plenty of room for improvement in the future. And with that, I'll stop and we'll hear about metastatic disease. Thank you.
Thank you so much, Dr. Sondak, for that brilliant overview and the exciting developments coming down the pipeline. I just want to quote something that somebody put in our chat. Wow. And representing the Canadian perspective is Dr. Marcus Butler. Dr. Butler is a medical oncologist and the medical oncology lead for melanoma and skin oncology at the Princess Margaret Cancer Centre in Toronto. His incredible research focus centers on developing novel therapies and clinical trials, including targeted therapy, immune modulation, and adoptive T-cell therapy. Excuse me. It is my absolute pleasure to hand the screen over to Dr. Marcus Butler. Dr. Butler, the floor is yours.
Thanks, Kathy. Yeah, and thank you so much for the opportunity to speak to everyone today. These are my disclosures. So at ASCO, Dr. Stephanie Goff gave a really nice figure that showed all of the developments over the last few years in melanoma, both for locally advanced as well as metastatic disease. We've really come a long way with a lot of treatments that are now available. And most recently, there was the combination of nivolumab and relatlimab, which was approved in the U.S. in 2022 and has recently been implemented in Canada over the last couple of years as well. There was a 5-year update of the clinical trial for Opdualag, or this combination of nivolumab and relatlimab. In that study, they compared nivolumab given once a month to the combination of Rela and Nivo. And in that study, there continues to be a superior improvement of this combination therapy compared to single agent nivolumab, so that many more patients are still alive at 5 years compared to nivolumab alone. Now, we also use another combination immunotherapy that's more toxic, ipilimumab and nivolumab. And in one of the sort of posters that looks at what you're not supposed to do, which is compare trials that were not done at the same time, there is an analysis that's presented where perhaps the results of Ipi-Nivo and Nivo-Rela are similar, and where patients are able to achieve the same results without the same level of toxicity. This is not definitive, and people are making decisions based on their conversations with their doctors and thinking about the pros and cons of the toxicity of the different regimens. But one of the outstanding questions has been whether this combination, nivolumab and relatlimab, or otherwise called Opdualag, whether this combination works in the brain. At an earlier conference a few months ago, the Bluebonnet study that came out of MD Anderson was reported. And in this study, they looked at patients with brain metastases that were not treated with radiation or surgery, but just treated with Opdualag, what the activity of that regimen was. And it turns out that, at least in this single arm study with the small number of patients, 20 patients, the response rate was high, with 30%, 6 patients having a complete response and 4 additional patients having shrinkage of tumors. Here you can see an example where a patient was treated and had a response to therapy. I think what this study really just shows is that for patients who are very interested in avoiding the toxicity of combination ipilimumab and nivolumab, but they have brain metastases, that the utility of this lower toxicity combination is a reasonable choice to consider. However, we have much more long-term evidence of the activity of the combination in patients, of the Ipi-Nivo combination in patients with brain metastases. There also was an interesting study that was presented looking at a new combination targeted therapy for metastatic melanoma, BRAF mutations. In this study, patients were given a BRAF inhibitor that inhibits both dimers and both monomers and dimers, which the dimer of BRAF is associated with some of the mechanisms of resistance for the standard classical BRAF inhibitors. This was also combined with a MEK inhibitor, and both of these drugs are of interest because they're able to get inside the brain. And that's a major problem with targeted therapy, where patients have brain metastases but don't respond as long in the brain, even though outside of the brain there's clinical responses. In that study, it's still a small number of patients. It's in phase 1 dose escalation and cohort expansions. There was a reasonably high response rate, especially for patients who previously had targeted therapy before. You wouldn't expect the response rates to be super high, but there was a response rate in the 20% range with a good disease control rate. And more importantly, there was even activity proven in the brain for these patients. So there's more to come with this combination, I think, in the future, and we'll see how it develops and whether it's also able to get into the adjuvant setting, the early disease setting as well. And in terms of just wrapping up, in terms of targeted therapy, there was an exciting presentation on darovasertib crizotinib. This is another type of targeted therapy that's used for patients with uveal melanoma, or GNAQ and GNA11 mutations. This is a treatment that targets an activated protein called protein kinase C. And what's really unique about the approach here is that darovasertib, which has sort of limited activity by itself in treating patients with uveal melanoma, metastatic disease, was combined with crizotinib for its ability to inhibit MET, which is activated in patients who have metastatic disease. And the two drugs together has resulted in improved clinical responses. The clinical study, that's a randomized study compared to immunotherapy versus the combination of darovasertib and crizotinib, resulted in a much higher rate of improvement. About 30% of patients had good, deep responses to this treatment, compared to about 8% of patients who received immunotherapy. This treatment isn't without its downsides. It does cause side effects, diarrhea, nausea, as well as edema. It's quite uh, uh, nausea or vomiting inducing agent, but there are ways to get around it, and patients are able to be maintained on the treatment and live normal lives with this therapy. But we're really excited about a new treatment for uveal patients, which in the past has really been a hard type of cancer to treat. And in terms of what's on the horizon, in the U.S., lifileucel has been approved since 2024. This is a cell therapy that's made from the patient's tumors where the T cells are expanded after a surgical removal of a tumor deposit. And lifileucel has been approved in Canada in 2025. We're currently undergoing the health technology assessment for the provinces to make a decision on whether to reimburse the cost of this medication. The lifileucel history was reviewed by Dr. Goff at the meeting, and basically the point of this treatment is that for patients who have exhausted all other therapies, there can be a clinical benefit, a response rate of around 30%, as well as a disease control rate. And when we look at the long-term outcomes of patients who've received these treatments, about 20% of patients are alive at 5 years, as opposed to what would be expected, a much lower number for patients receiving standard chemotherapy. But as I mentioned, lifileucel requires a big surgery. It also requires high-dose chemotherapy. It requires admission to the hospital where you get high-dose aldesleukin or IL-2 therapy, which is fairly toxic. There was a really interesting abstract that was presented by Dr. Bedoff, who presented early data on OBX-115. You'll hear people refer to this as the Obsidian study. And in this study, TIL therapy is given to patients. However, they don't necessarily need to have a big surgery. We can do the TIL harvest based on needle core biopsies, where you can actually biopsy several sites of disease as opposed to just one tumor. The tumor sample is then grown in vitro, where you expand out the tumor infiltrating lymphocytes, the TILs, and then you engineer the TILs with a novel gene called IL-15, which will only turn on when you take a simple pill called acetazolamide. It's a medicine that you can take when you go mountain climbing. And the acetazolamide causes the gene to be, or causes the protein to be expressed on the cell surface. And this protein, IL-15, is able to help the TIL cells become more activated and more effective and provide memory also. So in that study, even though it's a small number of patients who've been treated so far, they had a huge response rate of around 67%. I think there are some issues with patient selection. These are patients who haven't had a ton of prior therapy, but it's very promising in terms of being an option for patients who've failed to respond to prior immunotherapy treatment. And what's also exciting is that while you do see side effects from this medication, the grade 3 and grade 4, which means basically severe side effects, are much less present in patients. And you can see here on the graph that the grade 3, grade 4 toxicities are pretty rare compared to overall for patients, so the treatment's very well tolerated. This might make it possible for patients to receive lifileucel, sorry, to receive TIL therapy where they're not really well enough to receive high dose treatments like that are required for lifileucel. And then there was one other interesting cell therapy that was studied. This also is a patient population that is heavily pretreated and offers a way to treat patients who otherwise have no other clinical options available other than chemotherapy. And this is a treatment called Anzu-cel. This is where patients have a requirement for being HLA-A2 positive because the T cell receptor that's engineered into the T cells is able to recognize a tumor antigen called PRAME that's only able to be recognized by the engineered cells if you have HLA-A2. PRAME is highly expressed in patients with melanoma as well as uveal melanoma, and results of their early study were presented at this meeting. There was a high response rate in patients with both cutaneous melanoma as well as uveal melanoma. And these responses appear to be durable and are very promising. Again, the side effects are more manageable than what we typically see with lifileucel. There are some issues in a small percentage of patients with some of the scary side effects that you see with CAR T cell therapy. But patients were able to tolerate this therapy and were able to be managed with the side effects that developed. So in any case, these new treatments are very promising and hopefully will be continue to be showing results in the expanded clinical trials. The Anzu-cel, this last treatment, is currently the subject of a large phase 3 trial that is open in a few sites in Canada as well as several sites in the United States and as well as Europe. So in summary, metastatic melanoma, we have many options for first-line treatment. There's Ipi-Nivo, Nivo-Rela, monotherapy with anti-PD-1, but making a decision on which treatment to go with involves balancing the pros and cons of side effects and known benefit. We are seeing results that are promising in targeted therapy, and hopefully there'll be further development of this therapy for patients. And for resistant melanoma, there are lots of activity in this space, especially with cell therapy as well as other approaches. And hopefully these results that are promising now will result in approvals in the future so that patients have more options. So with that, I'm happy to chat more about all of these treatment options.
Thank you, Dr. Butler, for that incredibly insightful perspective. It is so encouraging to see the progress being made in the melanoma space. I think the three of us have been around for over 20 years, so we've seen melanoma going from very few options, if any, to where we are today. So let's hope the science keeps moving us forward. We're now going to open up our moderated panel and Q&A. To our audience, please drop those questions into the Q&A box on your screen. So I'm going to get us started. I kind of want to ask you both the big picture question. We saw, a lot of complex data coming out of ASCO this year. For a patient or a caregiver sitting at home today trying to digest all of this, what do you think is the single most groundbreaking or hopeful takeaway from the 2026 meeting? And I'll open it up to both of you.
Oh, yeah, I'll start. I think that, I mean, Vernon and I also kind of talked about this at the poster session. We, I mean, this ASCO it wasn't like the first time that we saw um, the Ipi-Nivo data or the first anti-PD-1 therapy data, or even like if you go back to the time when ipilimumab was first produced, because at that time, no treatment had ever been shown to improve survival. So this was a more incremental meeting. We're seeing progress in all fronts, which I think is the take home. There's progress in all fronts, but nothing has been groundbreaking in my opinion. You could even argue that the uveal melanoma, which shows some really promising results, it's also frustrating because we're waiting on overall survival data, so therefore patients don't have access, even though these treatments are there, and the overall survival is really required before it's generally available to patients. Anyway, I'm curious to see what Dr. Sondak has to say.
Well, I agree. I would go back to what I said about the bar has been raised. I think that's true across the entire spectrum. During the course of my career, I've seen such dramatic changes in the way melanoma patients are taken care of, and almost all of them are for the better. We still have really tough nuts to crack. Eye melanomas, for example, melanomas that have failed all the immunotherapy. I would say there were a couple of things that were really exciting to me about this ASCO meeting. Just I remember when you and I as you said, we're talking at the poster session about what we'd talk about today, but we were surrounded by literally hundreds of people. There were so many people at that session and at the other melanoma sessions, and there was so much cutting edge activity going on. No one of them was, oh my gosh, this is a breakthrough. But I think everyone has been energized in the whole melanoma world by the progress we've made. And if I would have to say, that was the message I took home. I was excited to see so many people all saying the same thing. Yep, we've made a huge amount of progress, but we have to keep doing better. We're not there yet. The other thing that constantly struck me at the ASCO meeting is a little bit of a backhanded compliment. Once upon a time, when we were studying things like interferon and interleukin and using chemotherapy drugs like dacarbazine, literally the rest of the oncology world paid no attention to melanoma. They said, you use drugs that nobody else wants. Nobody has any interest. You are studying these things because melanoma doesn't respond to anything. Suddenly, something happened, and now all the treatments that Dr. Butler was talking about, those cellular therapies, these targeted drugs, all of these agents, neoadjuvant therapy, the personalized vaccine strategies, everyone in other tumor types is saying, is that working for you? Can we use that in colon cancer? Can we use that in breast cancer? Can we use that in esophageal cancer? To see these drugs make such a big impact across all of oncology is remarkable. So we haven't just raised the bar for melanoma. I think we've helped raise the bar for all of cancer care, and that's also exciting to see.
Well, before I get to the first question in the chat box, I have to say that's because of people like both of you that have stayed dedicated to us melanoma patients when, things were not looking good. So I think, we all owe a huge gratitude to both of you, and I know I personally do. So I'm going to start with some questions, though. Dr. Sondak, I think one is probably from you or for you. Are there studies looking at better options for stage 1 melanoma that are less than 8 millimeters? It seems far too many become metastatic.
So there is still work going on in even the thinnest melanomas. Typically, that work is done by surgeons and dermatologists who don't always come to the oncology meeting, the cancer meetings. So we often hear about that at some of the other studies, Society for Melanoma Research, some of the dermatologic meetings, Society of Surgical Oncology. Um, and if and you are correct, the person asking this question, there are so many melanomas that are thin that even if only a few percent develop metastatic disease, it adds a lot to the total burden. But there, if we're talking about a 2% risk of spread, you can't treat everybody. So that's what I was getting at with some of these artificial intelligence things, some of these gene expression profiles. We didn't have time to go into a whole lecture, but I could lecture for a whole hour just on how do we pick out the one or two really aggressive tumors out of the 98 that are going to do fine. Until we can get there, it's going to be hard to make progress. But that is an active area of research, just not so much on the oncology, uh, you know, uh, drug treatment side of the equation.
If the
Dr.
gene expression profile was positive for a less than 0.8 millimeter, would you do a sentinel node?
So that was one of the findings of our study that was very provocative. Um, there are some guidelines and the NCCN guidelines, some others. A lot of surgeons do sentinel node biopsy for patients less than 0.8 if they think they have clinical adverse features, if they're very young, if they have a lot of mitoses or some other things. It turned out when we looked at that, none of those other features really translated into a 5% or greater risk. But if you combined those clinical features and a high risk gene expression profile, it did look very much like that was the subset of the subset that
Mhm.
we should be focusing on. And as a hint toward finding that needle in the haystack. But those are small numbers. I hope we can continue to study this and really nail that down, because that would begin to do what we're talking about. Take out of 100 people, there are 3 who should be getting a sentinel node biopsy. Let's not do it on everybody. Let's do it on those 3. All right, if we have to do it on 5 to find those 3, I can live with that. But we can't do it to 100 to
Yeah.
find 3.
Dr. Butler, I got a couple questions around the TIL, so I'm kind of directing them to you because I think they might be more Canadian specific. What's the procedure when a patient with BRAF wild, after responded of ipi-nivo patient had progressed on nivo solo? The TIL's not an option, so I'm guessing this is probably Canadian. Is there any other options for these patients?
Yeah, the only be basically lifileucel's currently not funded by any of the Canadian provinces. Some very wealthy Canadians have gone to the U.S. for this option. But even though it's Health Canada approved, it still is under review by Canada's drug agency, and that is an ongoing effort that's happening now. But I think it's going to be a few months at least before any decisions are made. There are clinical trials. There are several sites that are doing the Anzucel TCRT therapy trial. The Obsidian study is open at sites in the U.S. and they are taking Canadians, and it's, from what I understand, it's not cost prohibitive at many of the sites because there have been some Canadians that have gone to U.S. sites for the Obsidian TIL, but that's the current slots in Obsidian OBX 115 are very early lines. So if you've had multiple lines of therapy, you won't be able to fit onto that study. And then for the for the other study that I mentioned, it's a randomized study. The Anzu cell study, you need to be HLA-A2 positive, so that is about 50% of the population. So beyond that, there are also phase 1 trials in many of the cancer centers, as you know, as we're trying to develop new treatments for patients.
There's a follow-up sort of to that too. Is there a test to check the likelihood of the success of TIL therapy prior to the treatment?
I wish there were, but currently there's no way to predict who's going to respond. There are some strategies to try to get better harvests and better product, but even that is still a black box, and it's basically you've got to try. One of the things that I think for standard lifileucel patients with rapidly advancing disease, uh, you know, really sick patients or high LDH, it's unlikely you're going to benefit from that therapy, and getting another type of therapy may be in the patient's better interest.
I've got one more here. I had a 5 millimeter nodular melanoma, but have PMR. I was not offered immunotherapy because of prednisone use. The question is, when does time run out for immunotherapy post-surgery?
So we frequently don't use immunotherapy post-surgery in a preventative way, in part because the results in the end are often just as good if we wait. It's kind of like there was a commercial way back when: you can pay me now or pay me later, right? You know, many people want to be proactive and say, I don't want this cancer to come back. Even if you could treat it when it'll come back, I'd rather get it taken care of now. But if there are a lot of risks associated with that treatment, like the patient who has an autoimmune condition, like the patient who has an organ transplant, you say, no way, we want to kick this can as far down the road as we can and use that immunotherapy only when there's absolutely no choice. So we usually want to start adjuvant therapy within 8 weeks, 6 weeks, 12 weeks at the outside of surgery, or else we might as well just keep monitoring the person. But when there are really high risk features associated with treatment, then I think the balance of risk versus benefit is, let's monitor this very closely. The immunotherapy will still be available in the future. Let's not burn the bridge now and cause side effects that might not even be necessary.
I wonder, Dr. Sondak, would you consider targeted therapy in a patient who is really eager to be proactive in that setting?
Certainly, if they have a BRAF mutation, we've used that a lot more in the patients who have an autoimmune condition or an organ transplant, something where immune therapy might carry extra risk. That's not always possible, right? Not everybody has the right mutation. And in stage 2, technically, it's not approved even in the United States, but it's certainly something we would prefer if we're going to be proactive to use the targeted therapy against the BRAF gene. Yeah.
Yeah, that's a good point. That, you know, in terms of U.S. versus Canadian, often the eligibility, it's a little bit, our provincial insurance is often a little bit harder to deal with than in U.S.
Yeah.
Dr. Sondak gets on the phone with and does a peer-to-peer review, and is often more lucky than I am when I talk to the health minister.
Well, we'll have to change that, Marcus.
Sounds good.
That would be great.
Well, we're coming to an end of our hour, and I really want to extend a massive thank you to Dr. Sondak and Dr. Butler. Thank you for your dedication to research, your exceptional care for patients, and for generously sharing your time with us today. I know how really busy both of you are. Thank you also to our wonderful partners at AIM at Melanoma. To everyone watching at home, please remember that you are never alone in your journey. You can stay connected with both of our foundations using the information on the screen right now. If you need support, navigating resources, or just someone to talk to, please reach out to us at saveyourskin.ca or aim@melanoma.org. As a reminder, a recording of the entire webinar will be emailed to everyone who is registered, so you can rewatch it at your convenience on both our websites and YouTube channels. Thank you all for joining us again today. Stay safe and have a wonderful rest of your day. Thank you.
Bye-bye.
Thank you.
All right. Thanks very much. Take care.
All right, good to see you.
Good to see you too. Bye-bye.